I also wanted to kind of validate people in their experiences and show that there's nothing wrong with us or our bodies. There's nothing wrong with being Black or belonging to another group that is discriminated against. That means that you're sort of destined to become ill. That's not how it works. It's very much that by living in an environment where there's racism and there are social inequalities, that's what leads to worse health outcomes. And I think by recognizing that, it means we can start to tackle the problem. Because if it's just an inherent thing, if there's like something about being Black that means you're going to get ill, there's nothing we can do about that. You can't change your race, right?
This week I'm sharing part of my conversation with Layal Liverpool, who is an author and science journalist specializing in virology and immunology. Now, Layal has worked as a biomedical researcher at UCL, University College London, and at the University of Oxford. Her writings appeared in Nature, New Scientist, Wired, The Guardian, and elsewhere. Now, in this episode, we're going to cover a topic that gets a lot of people's heckles up. And so I ask for your patience and consideration because Layal has a lot of really interesting research to share about the impact of racism in healthcare. So you're going to hear us in this part talking about the difference between perceived racism and actual racism. We're going to talk about what race actually is, how racial categorization works generally in practice, and also specifically within the healthcare context. We talk about the idea of race being a social construct and how misconceptions of what race is and how it works can lead to negative health outcomes for people from different racial backgrounds. We talk about the misconceptions of Black diseases and white diseases. She helped to clarify a lot of misconceptions that I personally had, and I'm sure many of you might share. We also talk about racism in maternity health and the concept of racism being considered as a public health issue. So this is a really interesting episode, specifically personally for me, and I know for lots of you out there. You can get the full show notes, the transcript, and read my newsletter at theknowledge.io, and you can find Layal on Twitter at Layal Lives. Her website is layalliverpool.com. We'll have all the links in the description or show notes, and you can find her debut book, Systemic: How Racism is Making Us Ill, in all good bookstores, and we'll have links again for that. So if you love this episode, please do share it with a friend, and don't forget to leave a review wherever you listen to podcasts, because it helps us tremendously to find other listeners like you. And last thing, there's going to be follow-up parts to this, so please do subscribe so that you don't miss that. One question I did want to ask, actually, and maybe this is where we can start. I was just interested to know where your name was from. It seems like a really interesting turn of events that your surname is Liverpool, and you studied in Oxford, and you're based in Berlin. And
yeah, it's very confusing. I think people often get confused by my name. So yeah, my surname Liverpool. I mean, we believe it's a kind of slave name. So my dad is half Ghanaian, half Dominican. So Dominica is a small island in the Caribbean close to Guadeloupe. Yeah, so we think that's one of the ancestors on my father's side was enslaved and passed through or was trafficked through the port of Liverpool in the UK. So Liverpool was a major slave trading port. And I have actually had the pleasure to visit Liverpool. A few years ago, I went there for actually like an immunology conference, and I managed to find time to go to the International Slavery Museum there. And it was really interesting because I could learn a lot about the history. And I think with slavery, often that it feels like a gap in the story or history. You don't often hear the stories told by, enslaved people. Yeah, so it's kind of, I think I like my surname. I think it's sometimes people, when they ask about it and I mention slavery, they kind of feel awkward or uncomfortable. But I think it's kind of good. It's a good maybe conversation starter to think about all of our histories, how we're all connected somehow. And so I found it kind of a learning, a good learning tool.
I actually think that's a perfect starting point, because just like what you were saying, I think that race can often be, in general, this kind of nebulous thing that people dance around and makes people a bit uncomfortable whenever it comes up. And this idea that there's a tension between the idea that people may be racist or may say something racist or think something racist, or they think something and it may come across as racist, but does that make someone racist? And then you also have outcomes in society where, okay, the outcome may produce some racial disparities. And what does that mean? Does that mean people are racist, or does that mean this? Does that mean that? I mean, how do you think about that or navigate those ideas?
Yeah, I think this is something that's also come up a lot talking about and researching the book. People often want to talk about, oh, who is racist? And particularly thinking about racism and how that affects our health. And in medicine, it's like, oh, there's this particular doctor is racist, or let's talk about that. But I think it's actually, maybe it's less catchy, but I think often it is the systems and structures, institutions that underpin our society, our lives, that lead to a lot of racial disparities in health. And I think those systems are racist, and it's good to name racism as a problem in society, also as a public health threat. But yeah, I think, of course, the actions of individuals are important too. And I also talk about that in the book. I look at interpersonal racism and how those interactions can also affect our health. But I think probably the larger contributor to inequalities in health comes from systems. It comes from, for example, medical guidelines that embed racist ideas from the past that are still affecting people's health today. And yeah, I really want us to be less scared of the word racism. Unfortunately, it's a word that often evokes, as you say, maybe defensiveness or fear talking about that. But I think being able to talk about these things is really important to be able to then start to tackle the problem.
And I think in your work, in many of the articles that you've written, and I'm sure in your book, you talk about how this comes up in different types of circumstances. And I thought maybe a good starting point might actually just be to define what we mean by race as well. Specifically because I think there is an interesting conundrum that comes up when, on one hand, sometimes you hear people say, oh, race is just a social construct. And actually, people are people. It doesn't matter if you're, red, black, or yellow, or, whatever people say. But then simultaneously, on the other hand, like you can see statistically that sometimes either that there may be some real racial differences, or at least that you just have some racial disparities in whether it's medical outcomes or outcomes in other types of areas. And so it's a strange balance of, okay, on one hand, people want to say, oh, actually, we're colorblind, everyone's the same. Obviously, we shouldn't treat people differently because perhaps people are no different. But then in reality, simultaneously, it seems like maybe there are some differences.
Yeah, I'm really glad you brought that up. I think that that's a really important thing when we start to talk about racial inequality. I think it's really important to think about how racism contributes to that. I interpret race and racism very broadly in the book. So I'm looking at all forms of discrimination that are racialized. This includes, Islamophobia, anti-Semitism. There's also discrimination against white ethnic groups. So I interpret that broadly, but I think it's also important to recognize that there's a lot of what I would call anti-Blackness that is very, very strong when it comes to, for example, the history of medicine. And that also stems from the fact that I think racism was very much kind of perpetuated in an era of European colonization, transatlantic slavery, and used to justify those things. So, of course, it's easier to kind of justify the oppression of a group of people if you can use sort of science or pseudoscience to paint those people as inferior or deserving of worse treatment. And of course, that's historical, but we know that these things continue to affect us until today. And I think the way you mentioned that race is a social construct, and I completely agree with that. I should say the evidence, is clear that there's no such thing as race in a biological sense. So, 99.9% of our DNA is the same. There is research looking at, for example, genetic differences between geographic groups or so-called racial or ethnic groups. And that research shows that, 95% of the variation that we see exists within so-called geographic or racial groups compared to between groups. So it's clear that there's no such thing as race in that biological sense. But I think race is still a very real thing in the sense that we do experience that as a social construct. It does affect our lives and our experiences. So I think race is a social construct. It doesn't have a biological basis, but racism does affect our health. And there is evidence that it can have a biological impact. So I think we shouldn't dismiss the harms that racism can cause on our biology, on our bodies. And I think that distinction between, are we talking about differences in race or are we talking about differences due to racism, is something that's very important to me. And I try to make that clear in the book as well.
Okay, this is really interesting. And I want to try and repeat back what I'm like understanding or passing from what you said, and you can correct me where I'm making some mistakes. I think what you said that really is interesting, or at least where it took my mind, is this idea that potentially there are definitely certainly differences in different cultures. And there are some genetic differences in, people that grow up in different places. There are differences in gene pools, etc., etc. And so that can manifest in lots of different ways. And so you might have oh, there are some people in these different ethnic groups where they happen to also have, melanated skin, or so they look black, and they might have these distinctions here. But it may just be that, race itself is a very poor container for categorizing those distinctions. And so you might have, okay, between lots of different ethnic groups or between different people from different cultures, etc., there may be some of those differences, but actually using race as a container by which to categorize people is substandard. It doesn't really do an adequate job, perhaps because there is within those racial categories so much difference. And actually, that brings to mind a conversation that I was having with Garrett Jones, who has done a lot of work talking, or at least thinking about, some of the potential IQ differences, let's say, between different races or different cultures, etc. And I know that that's always been an ongoing conversation about, do some racial groups have higher IQ than others? And one thing that I found interesting from some of the discussion that we had is that simultaneously there is more, even if you were to accept that there are some differences between, the IQ distribution of some races and of others, but actually the variety within each race is greater than the variety between different races. And so actually it's almost not useful. It might only be useful when you're thinking like about averages on a grand scale, but actually on an individual scale is useless, because there is so much variety within the race itself that actually it's not worth comparing between the races, as an example.
No, exactly. I think you got that exactly right. And of course, genetics is a very useful science. I definitely don't dismiss genetics I think it's really helpful for understanding. For example, you can compare groups of people who have a disease and a group who doesn't, and look for these small genetic differences to try and maybe pinpoint targets for future treatments. So there's a lot of benefit of looking at genes and looking at human variation at a population level. But I think sometimes we make the mistake of trying to apply that at a very individual level and to group people into these containers, as you said, and labels, particularly when we bring race into that. Another problem that I have with race in a sort of scientific context is that it is a social construct. And because of that, that means it varies a lot in time and place. It's very poorly defined. So in the book, I kind of lightheartedly give the example that, when I travel to Ghana, which is where my parents are from, I might be called Obrone, which is like something that means someone who's foreign or white person. Whereas here in the UK or in Germany where I live, I'm racialized as white. Or if I travel to Brazil or South Africa, how I'm racialized might change. And I think that just shows you how fluid and exactly a social construct race is, which is fine when we're talking about our social experiences. But when it comes to science or medicine, where we want to be extremely precise and have useful categories that can help us, for example, to diagnose a patient or decide about treatment, I think that's where race really doesn't have a place. And that's why I think it's important that we talk about racism and how racism affects health rather than race. And that might sound like semantic, but I think that that's actually a really important distinction and can really affect people's health outcomes.
Yeah. And okay, so making a part of a transition into discussing some of your work, one of the things that I've been thinking about earlier this week as I was preparing was just, it might sound a bit random, but I was just thinking about, okay, there's got to be some balance of where's the distinction between, perhaps there are some, let's say, genetic differences between different people or something like that. And, there are medical outcome differences. And one example that just came to my mind is just thinking anecdotally, I might not know the specifics about what causes some of these different diseases, but, I don't really hear anyone white talking about sickle cell, for example. And simultaneously, I don't really think I've heard any black people talking about having Lyme disease. And I just mentioned that because it came to my mind in passing of just thinking, these things seem different. However, from what I do know about sickle cell, some of that might make sense because actually, to my understanding, sickle cell is some evolutionary response to malaria. And actually, okay, fine. Perhaps where malaria is prevalent happens to be in places where there are lots of black people and there are not many white people. And so you might notice in day-to-day life that actually, it seems to be that most of the people that I see that have sickle cell are black people, and maybe there's some connection there in terms of genetics. And I
Yeah.
was thinking, oh, maybe there's something like that for Lyme disease as well, which I didn't know as much about. I did, some basic searches. It seemed to be almost the opposite, and I was so surprised that actually it turns out that the Lyme disease, perhaps there is some aspects of it that is similar, because I think it's a tick-borne disease that comes from horses or something like that, and so maybe part of that is just due to geography. But what I found really interesting is that there were news stories going back decades. And I was looking at, there's a study that came out in the year 2000, or at least article that came out in 2000 that was referencing studies that finished in, let's say, 1996 about Lyme disease, and saying, we've just noticed that there are these massive imbalances in the medical outcomes for black people versus white people that have this disease. And I was like, that's strange. That's interesting. Then simultaneously, in late as 2023, just a year or so ago, you also have a study that also just came out that I think was looking from the time period of 2008 to 2016 that had the exact same conclusion. And so you have this 25-year gap where actually people are just saying the exact same thing. Somehow there's this massive difference in outcomes. So even if it is the case that actually maybe a lot more white people are getting it, I think in the study that came out in 2023, they were saying, actually, it looks like black people are having to wait 5 times as long to get the antibiotic treatment for this disease. And that just seems strange. So what is happening there? Because it might not seem, if people think, my local doctor, is this person racist, or does this person have, something against black people? You might say no, but somehow in the reality of the treatment and people going through this process, suddenly these differences manifest. Hey, we'll get back to the episode in just one moment, but I wanted to tell you very quickly about my newsletter. I started sharing everything I was learning online, and a few thousand people came along for the ride. I send 3 regular emails. Brainwave, fortnightly on a Tuesday, which is about the intersection between technology, philosophy, and psychology. Then every week on a Thursday, I send Revelations, and that's about creativity and productivity. And then finally, every other weekend, I send Wayfinder, and that's about decision making. So people in the audience actually send me really tough problems that they're working through, and I help to deconstruct them using mental models and decision-making frameworks. So if you'd like to subscribe, you can join me and over 20,000 incredibly driven people at theknowledge.io. Okay, back to the episode.
Yeah, and I think in the examples you've given, you've just illustrated that it is complex, and there are a lot of different factors that contribute to health inequalities. But I think that perhaps we can talk about sickle cell as an example. I think the fact that sickle cell has been racialized as a black disease, you hear that a lot. And of course, you're right that the malaria is prevalent. We also see an association with the sickle cell trait because it confers protection against malaria. So it's true, but that part of the world is actually quite a large area where malaria has been prevalent historically. So that includes large parts of Africa, but also the Middle East, parts of India, Southern Europe. So that actually it isn't quite right to say that this is a black disease, although it's true that many black people are affected by it. And I think the fact that it has been racialized in that way has actually been harmful to sickle cell as in terms of investment and interest because of the racism that exists in our societies and anti-blackness. I think perhaps there's been a lack of sufficient investment in sickle cell because of that perception that, this only affects black people, which is obviously terrible. But we also see that in conditions which have been kind of racialized as white. So for example, cystic fibrosis is often racialized as a white disease, but in fact, it can affect, people of all backgrounds. And there's also evidence that racialization of cystic fibrosis as a white disease has been harmful to black patients who've then had to wait longer for a diagnosis. And you also talked about this example with Lyme disease. But yeah, we see this also in other conditions that might not be thought of as conditions affecting black people or people with darker skin, like skin cancer, for example. So melanoma and non-melanoma skin cancer. Of course, having more melanin in your skin is protective against skin cancer. It protects you from damage from the sun. But again, black people can also develop skin cancer. And in fact, there's evidence from the US that black people die from skin cancer at higher rates than white people. So even though they may be less likely to develop the condition, it seems that there are delays in diagnosis and in receiving treatment for black people, which leads to worse outcomes. So I think it's very important to be careful again by racializing these conditions, we're not really helping with those outcomes. And it's something that I thought about a lot also during the COVID-19 pandemic. because there was a lot of conversation about, okay, in the UK, for example, ethnic minority groups are being worse affected by COVID. I was even asked in a podcast interview that I did in 2020, is the coronavirus racist? Is this virus racist? And I think what I would say to that is that of course, viruses aren't racist, but our societies are. And there are extreme inequalities based on race. We see differences in economic outcomes, in environmental inequality on racial lines because of the history of racism, but also because of things that are happening today. We also see biases within medicine and in healthcare that contribute to those inequalities. So all of those factors together definitely contribute to unequal outcomes when it comes to health. And we do see that not just during COVID, but in other infectious diseases like HIV, but also in cardiovascular disease, cancer, which I've mentioned, but also mental health conditions. Across all of these different areas of health, we see this pattern that people belonging to marginalized groups are experiencing worse health. And that's not only true, here in the UK, but also in other countries, in the US, I've mentioned, but also, for example, in India, we see that there are inequalities based on caste, related also to skin shade or tone. So these inequalities happen wherever we see that there's racism or some discrimination against particular groups of people. Those people are experiencing worse health. And I think that is a pattern that is worth looking at and worth considering and prioritizing as a public health issue.
Okay, sure. I'd love to go more into the COVID example because I think that was a big part of the inspiration for your book. And you've mentioned that we should potentially consider racism as a public health crisis. So I'd love if you could unpack, what was it that was interesting or special about COVID that made you pay more attention to that?
Yeah, so actually, I think it wasn't maybe just me who kind of paid more attention. I think it was kind of the wider society. And I think that there was a lot of things maybe that happened in 2020 that brought attention to these issues beyond people who might have already been campaigning on this for a long time. So I think the inequalities, but also anti-racism protests that happened in 2020 around the world, I think put a spotlight on inequalities in our society, but also how that affects our health. And as a journalist, I was reporting on ethnic inequalities in COVID and looking at the factors that contribute to this. And what I discovered is that a lot of these inequalities have existed for a long time before COVID. And, doctors and academics who've been researching racial health disparities will have told you this, that, for example, during the H1N1 pandemic, so that's the swine flu pandemic that happened 10 years before COVID, we also saw ethnic inequalities in terms of who was becoming ill, who was dying from that virus. But I think perhaps during COVID, there was something unique and I guess really global about that, got people's attention and got people to notice some of these inequalities that were already present. During COVID, there was a lot of discussion of when it came to ethnic inequalities that, the reasons for this is that, for example, Black people are poor, or there are many Black people or people of South Asian ethnicity in the UK, for example, that we have pre-existing health conditions that make us more vulnerable to COVID. And I kind of found that argument to be quite circular because we're not asking the question, why is it that, for example, Black people are disproportionately experiencing poor economic outcomes or poor health? And the reason for that is when we look at the history and we look at our society today, the evidence really points towards racism, both historically, but also today in the way we lead our lives. There's evidence that racism causes stress, which can increase the risk of various conditions, including cardiovascular disease, which has been associated with worse outcomes with COVID. We also see evidence that there's bias within medicine and medical practice that leads to worse outcomes for people of color often. So I think it's important that we consider all of those things when we look at health disparities and recognize that there's nothing inherent about, being Black or belonging to a marginalized group that should make you more ill. But living in a racist society while belonging to a group that is discriminated against is harmful to your health. And that seems to be what the evidence is increasingly showing.
Okay. I want to try and put myself in the mind of someone that might be disinclined to believe what you're saying. And I think there
Please
might be
do.
plenty of people that, they hear about, this is happening because it's racist. And, people don't like that idea. And people say, oh, you're pulling the black card, or, why are you saying this happens like this? How might you assign the probabilities of, let's say, okay, we can accept that whether it's deaths or negative health outcomes during the COVID period, that there might be Black people may have been disproportionately affected by that, how might you assign the probabilities of, okay, here are some potential different outcomes, and okay, this I think is the largest part of the blame, and I think actually this proportion comes from here. You know, how much weighting do we give to, oh, just inherent within the medical system, there may be some biases that led to some negative health outcomes, or is there some proportion that is, oh, actually some people may be predisposed for such and such reasons, etc.
Yeah, so I won't give numbers because I don't really have, it's
Yeah,
difficult to put numbers on discrimination in that way, but I will give like my sense of the problem from, researching this, interviewing doctors, scientists, and also people who've experienced racism in the context of health, and also just from my own experiences. So I think that the largest contributor to racial disparities in health is systemic racism. The reason is that when something happens in a systemic level, that affects obviously a lot more people compared to individual instances of discrimination. Although I think those are also harmful and we should tackle them too. To give an example, I spend a lot of time researching what's called race-based medicine. So this is where race is embedded into medical practices and guidelines in a way that is inappropriate. And also increasingly the evidence shows that it doesn't make sense. It's not based in good evidence. So maybe to give an example, there have been guidelines for a long time to adjust lung function tests based on a patient's race, particularly for Black patients, that were based on this idea that can be traced back to a US physician and slaveholder in the 1800s. His name was Samuel Cartwright, and he had this idea that Black people's lungs are essentially weaker, and therefore that Black people benefit from being enslaved. And you can, of course, see in that historical context, there was very much this need to justify the enslavement and oppression of Black people. And so coming up with this science to kind of justify that in that context made sense. But unfortunately, some of these sorts of ideas, including this example that I've given, have made their way into medical guidelines that persist to this day. And it was only last year that the American Thoracic Society and also here in Europe, the European Respiratory Society changed their kind of joint recommendations when it comes to lung function testing. And they eventually acknowledged that, race is a social construct, exactly what we've been talking about today, and that it doesn't have a basis in biology. And so they no longer recommend adjusting those lung function tests based on race. But those sorts of ideas and practices are very pervasive in medicine. And I can give many more examples. There's, assumptions about Black people's pain tolerance being different that have been widespread. I recently became a mom and, going through pregnancy, it's clear that there are also racial disparities in outcomes, particularly in the UK, for example. Black women are 4 times more likely to die during pregnancy or childbirth compared with white women. And you also see patterns of racism and bias, for example, in the care that women receive. There's been really amazing work by this grassroots organization called 5 Times More here in the UK. They've done research showing that, 43% of Black and Black mixed women report experiencing discrimination in their maternity care. And in the survey that they did of Black women, they also asked for kind of anecdotal experiences that people had. And there have been experiences of people where their doctor, for example, has promoted this idea that Black women's pelvises are shaped differently than white women's, which again can be traced back to really problematic ideas, in this case from a British anatomist called William Turner, who had the ideas about, Black women's pelvises are inferior and less suited for childbirth. They're more close to animals and all kinds of really problematic and racist ideas. But I think some of those things make their way into science and we sort of lose that racist history. And then they just sound reasonable that, oh, Black people's lungs work differently. So let's just go along with that. But thankfully, a lot of medical students, doctors, so people working in the medical profession have been recently questioning a lot of these guidelines. And I think, perhaps the inequalities we saw with COVID in 2020, and then also the anti-racism protests that happened to occur in the same year, I think maybe that also forced an accelerated reckoning with these issues. So I hope that will continue because it's been great to see a lot of these guidelines recently being overturned. So I think this is something that is changing. I think we're increasingly recognizing that. But I think that is an example of how systemic biases have a greater impact on people's outcomes because, of course, if you're unlucky and your individual doctor is racist, that will be harmful. But if your doctor is following guidelines that tell him or her to adjust your, test results based on your race, and that's going to have a huge impact because all patients are kind of affected by those guidelines. So I think systemic biases have a huge impact within medicine, but also within wider society. So I'll pause there, but I can talk more about, how our living environment affects our health and all of these things that are also kind of systemic problems.
Yeah, you've touched on so many things that I'd love to come back to and double click on. But one thing I just wanted to double down on is a really important point that you mentioned that I think is really important for
Hmm.
people to understand is that, again, I know a lot of people will instantly just balk at the idea of, oh, you're telling me I have some beliefs that happen to come from some racist place or from something like this. And it's so interesting how, even as you say it, a lot of it makes sense intuitively to me that someone at some point in history could have just made something up, or, they had some incentive to say something, and that can just spread throughout history, and
Yeah.
it can become quite innocuous where suddenly we hold this belief that doesn't really have a real medical basis. And there might be people that hear that and think, oh, I can't believe that's true. How can you just say that, some of this science is made up? But it's so easy to believe and understand that it's true when you realize how many other areas of our lives we have these implicit things that come from. And I remember I wrote a post about this a while ago, just talking about how many of aspects of people's daily lives are actually just psyops from the past. And so, there's a bunch of great examples. For example, you might ask, oh, why do people have long lunches in France? And people say, oh, it's just part of the culture, and, French people
Yeah.
culturally, this and that, blah, blah, blah. Actually, this came from the Industrial Revolution as a way to stop airborne tuberculosis. Like, people were dying in the factories because they all had to come into Paris, and they were working all day in the factories. And at some point, so many people were dying that they were like, okay, we need to get everyone out. Let's clear out the factory for for
Mm.
a little while in the middle of the day, so that we can air it out, and then people can come back. And that's where the long lunches started. And actually, the women's rights movement in France started because at this point that everyone had to come out and leave the factories, there were, people were harassing the women, and actually they were arguing that they want to be able to go back inside and have their lunch in peace, indoors inside the factory, and not have to be, facing all the lewd men outside. And so it's funny how,
Right.
okay, that started as some tiny little thing, some small little policy in the 1800s to stop airborne tuberculosis. And now French people think, oh, it's part of the je ne sais quoi, and, this is just our cultural artifact. And
Yeah.
actually, it just comes from this random thing. The same thing with, let's say, home ownership in the UK, the same thing with breakfast. Someone just made up the food triangle, which now we know doesn't really mean anything factually. But suddenly, oh, breakfast is the most important meal of the day. And again, this idea that so much of the way we think about food and the way that we think about what we eat just comes from adverts and lobbyists. And
Yeah.
actually, some of these things are not even that old. And I think that's the key fact as well. With some of the things you're talking about, they actually go back hundreds of years, which
Yeah.
should only amplify their power. But there's some things that we live with day to day right now that actually are only a few decades old. And a few decades ago, someone decided that they believe this thing, and they put that idea out into the world. I was talking about pad thai as an example.
Hmm.
Pad thai, I mean, it's going to sound bad, but it doesn't really exist. When
It was
when
invented.
Indonesia was changing from Siam, they went through a period of nationalism, right? National pride, and so they just started calling a lot of things Thai things because that's the new name, like Thailand, Thailand, Thailand. And so they just took this recipe. It was an old Chinese recipe. They printed it in the newspaper, and they said, "Okay, this is pad Thai." And literally, that just happened one day. And suddenly, this is now the new national dish, and everyone's like, "Oh my gosh, I love this thing!" Blah blah blah. So again, just this idea that someone at some point in history could just completely make things up, and it can shape so much of our lives, so much of our culture without us realizing it, happens in many areas of our lives. And I don't even think people realize that to start with. But I think once you do realize that, then it's also very easy to realize that actually some of these things were done by racist people. And there could have been someone that happened to be racist or happened to have racial beliefs at some point in history. And simply because they said something, it has now proliferated through time. And now lots of people have these beliefs. And maybe to
Yeah.
connect this to something that you've talked about is this idea that within the medical system, there are people that have certain beliefs. There was a really interesting study that I looked at. I'm not sure if it was you that shared it, actually. It was interesting to note that I think they looked at particularly just white doctors and the beliefs that they hold. And you can see that almost there's a correlation to the number of years of training that they have, where when they start, they have all these crazy beliefs about, oh, white people are like this, black people are like this, white people have larger brains, black people don't have, strong pain receptors. And obviously, by the time they become resident after many years of training, once they actually have some facts and better knowledge, they actually don't have as many of those beliefs that they once had. But that tells you that those beliefs come from somewhere.
Yeah.
And it might not necessarily be that, oh, they themselves are racist, because you see their beliefs change over time, or at least based on the number of years of training that they have. But if they are coming into the medical system with those beliefs, that tells you that those beliefs are already percolating in society. And
Yeah.
so actually, just as a person that had started medical training, they are coming into the system believing a bunch of these things, and it takes a certain number of years to kind of weed through those beliefs.
Yeah, and I think you're so right about sometimes these ideas are very sticky. And I think racism is an idea, right? It's an idea of superiority and inferiority, and it has been persistent. But also these more specific examples of beliefs in science, but also in medicine, have also been persistent sometimes and continue to affect people's health. There was a study in the US of, I think, mainly white medical students and residents found that about half of the students endorsed beliefs such as, black people's skin is thicker than white people's, or that black people's nerve endings are less sensitive. And so these ideas do seem to sort of persist. But I think by discussing this and highlighting racism as a public health issue, it also helps to frame those discussions within medicine and within science. And it's been great to see a lot of different fields of medicine reviewing some of their guidelines that have been based on race. I think a lot of that reckoning started in 2020, actually, like following George Floyd's murder by police in the US. I think there was a wider discussion about racism, and that, as you've pointed out, there's racism in society, but medicine exists within society. Doctors are going home and watching the same TV shows that we all watch, and they're influenced by all these stereotypes and ideas. And so I think it's been good to see that reckoning happening in medicine. What I would love to see more is, I think there's been a lot of reflection within specific subfields of medicine. I've done a lot of work, for example, with nephrologists, and eventually that led to changes to kidney function test guidelines that were also racialized. There are many other fields which I think we still see these racist ideas. And I think it would be great to have a wider review of the use of race within medicine in general, and just to interrogate these assumptions one by one and ask, is this coming from some context, some historical racist context that isn't relevant today? Or can we just double check all of these things and make sure that, is this based in evidence, or is this just one of these sticky ideas that's kind of hanging around? Because I think in medicine, it's so important that we're evidence based and that we're up to date as well. So that's something that I would love to see more of.
Okay, so one question
Mm-hmm.
that I wanted to ask as a follow up to that I think is quite intuitive there is, so how do we find this balance then? Because on one hand, we can acknowledge that it seems to be the case that there are some disparities. Does that mean that maybe we should pay more attention to race in some circumstances and actually think about it? But then simultaneously, part of the problem is that there's already, quote unquote, race-based medicine where
Yeah.
people are factoring in race when making certain diagnoses, and that's part of the problem. So how
Yeah.
do we balance those two ideas?
I think that's such a great question. That's something that I've been thinking about so much, and especially researching and writing the book. I think it's the question of, how should doctors consider race? How should race be considered in medicine? And I think what I'd love to see more of in medicine is that doctors will be thinking about how racism affects their patients rather than race. So I think there are many instances where we talk about race, where I think we could actually instead be talking about racism. So we hear a lot of these statistics. You hear it all the time. Black people are more likely to die with COVID or during childbirth or from cardiovascular disease. And the way we frame that, it makes it sound almost permanent or inevitable, as if there's something inherent about being Black that is bad for your health. And I think this is also something with the book. I also wanted to kind of validate people in their experiences and show that there's nothing wrong with us or our bodies. There's nothing wrong with being Black or belonging to another group that is discriminated against. That means that you're sort of destined to become ill. That's not how it works. It's very much that by living in an environment where there's racism and there are social inequalities, that's what leads to worse health outcomes. And I think by recognizing that, it means we can start to tackle the problem. Because if it's just an inherent thing, if there's like something about being Black that means you're going to get ill, there's nothing we can do about that. You can't change your race, right? But racism is something that we can do something about. So by naming that and recognizing all the harms that racism causes, it means we're saying, hey, this is a problem that we can fix. And I think there's a lot of things that we can do to tackle the problem. There are just even basic things like we can teach doctors to recognize health conditions on diverse skin tones. I haven't talked much about this yet, but there are a lot of disparities in terms of skin health, but also recognizing conditions that might manifest on the skin, but might be more serious in the body. And yeah, there are issues with recognizing these things on diverse skin tones. Doctors might not have confidence to diagnose people. Can talk also about research in that area, but also just removing bias and racial bias from medical algorithms, as we've talked about, for example, with lung function testing or kidney function testing. So there's a lot of things that I think we can do to tackle this. And also in our wider society, just tackling inequality in general. I think tackling economic inequality, environmental inequality, these things are very much related and correlate with racial inequalities, also for historical reasons. So I think by tackling those issues, we're also going to help people to live healthier lives.
Thank you so much for tuning in. Please do stay tuned for more. Don't forget to rate, review, and subscribe. It really helps the podcast. And follow me on Twitter. Feel free to shoot me any thoughts. See you next time.